This is Lance Lichter for AA Today. Fluid therapy for kidney transplant surgery. When you care for a patient who is undergoing a kidney transplant, what fluid do you use for maintenance? If your answer is normal saline, your fluid choice matches that of the majority of anesthesiologists in the United States. The reason for this practice is, in part, because of the fear of causing hyperkalemia if lactated Ringer solution is used. The problem is that normal saline contains an excess of chloride ion, which can lead to hyperchloremic acidosis, renal vasoconstriction, and decreased glomerular filtration rate. The authors compared 150 patients undergoing cadaveric kidney transplantation who were randomized to receive either normal saline or chloride-reduced acetate-buffered balanced crystalloid. The results of their study are published in this month's issue of Anesthesia and Analgesia in the article titled An Acetate-Buffered Balanced Crystalloid versus 0.9% Saline in Patients with End-Stage Renal Disease Undergoing Cadaveric Renal Transplantation, a prospective, randomized controlled trial. All patients had both the central and peripheral line. Fluid infusion rate during surgery was set at 4 milliliters per kilogram per hour. Postoperative maintenance infusion rate was set at 2 milliliters per kilogram per hour until the patient was transferred to the ward. Both during surgery and perioperatively, the amount of fluid volume administered was no different between groups. Hyperkalemia was higher in the acetate-buffered crystalloid solution group, 17% saline versus 21% acetate buffer, while maximum chloride was higher in the saline group, 109 millimoles per liter versus 107 millimoles per liter. Metabolic acidosis, based on base excess deficit measurement, was greater in the saline group, minus 4 millimoles per liter, than the balanced crystalloid group, minus 1.6 millimoles per liter. Catecholamine use was higher in the saline group than the balanced regimen group, 30% versus 15%. There was neither a difference between the two groups in the need for dialysis until postoperative day 7, nor was there a difference with regard to urine output, serum creatinine, or blood urea nitrogen. The fluid tested in this study is not universally available. This article does serve to remind us, however, that normal saline is almost never the preferred intraoperative fluid, even in cases of renal failure. For links and more, go to aatoday.org. That's AA, the number 2, day.org. This is Lance Lichter.